So, welcome everybody. This session is Dr. Daghni Rajasingam, apologies. Daghni is a Deputy Chief Medical Officer and Consultant Obstetrician for Guy's and St Thomas's Foundation Trust. She's also Medical Director for Secondary Care Transformation for NHS England across the South East. Daghni is going to talk to us today about this year's International Women's Day theme, Accelerating Action, in relation to healthcare, leadership, and the dial in gender equality. Daghni, I'm going to bring up your slides for you now.
Good morning, everyone. It is an absolute delight and a privilege to be presenting to you on International Women's Day. So happy International Women's Day. I'm delighted to be doing something with our very valued partners, the Institute of Health and Social Care Management. I've been asked to talk about accelerating action. I'm going to focus on healthcare, leadership, and shifting the dial on gender equity. And hopefully I will do a relatively good job of warming you up for two fabulous women who are going to follow on. Next slide, please. So I want to take you through a little bit of the global, I suppose, the scene setting, because things are the way they are, because the world is the way that it is, and we are in a very, very weird and odd and disturbing global situation at the moment for a variety of reasons. But these key facts here around global gender equality, I won't dwell on them. They are the 13 facts around it. There are more than 13 facts as to why we have significant gender inequality across the world, irrespective of our education, irrespective of deprivation and affluence. And these are really quite sad facts, and they're incredibly sad facts for me as an obstetrician, because I have spent the majority of my professional career looking after and thinking about women. Next slide, please. So why are we where we are at? I hope that, and I suspect that most of you will have heard of Invisible Women, if not have read this book by Caroline Criado Perez. It's an absolute eye-opener. She goes through in each chapter a different aspect of society and why women are invisible. And if you are a woman of my age, I'm a postmenopausal woman, and proudly so, you can start feeling and seeing that invisibility really setting in. It's like this very big, deep cloak. And for those of you a certain vintage, you'll remember The Invisible Man. It was a series that was around in the 70s and the 80s. And it's quite nice when you have a choice. It's less nice when you don't have a choice about it. So it is interesting that women are generally the male default. Even in my specialty, gynecology, we tend to divide the pelvis, and that's that bit. We forget about the breast, we forget about the whole person, and therefore we get the outcomes that we have generally across the world in women's health. Next slide, please. But what is really interesting about it is that despite this invisibility that exists, we know when you look at the data around the McKinsey report, and there are many other reports that show you that even when you get gender diversity in organizations, and generally these are corporate organizations that they looked at, you are just more profitable. You make more money, you do better. It's a win-win all round. And often we grasp these things, don't we? When we know something's good for business, we grasp it and we do it. And yet with gender equality and equity, that really hasn't happened. If you then add on the layer of ethnicity, I am a woman of color, so I have intersectionality playing into my everyday life. As many of you will have a variety of other protected characteristics and intersectionality. When you put gender and ethnicity and you put it into the business case, it so totally makes sense, and yet we haven't shifted the dial. And there is a reason for that, and that's the reason for that is that we still have many systems that systematically and systemically are patriarchal and keep things as they are, so that women's needs and serving women becomes a secondary issue. Next slide, please. I just want to take you outside of healthcare for a minute. The Lasker Awards are the highest scientific awards in the United States of America. And if you look at this, men versus women in the top bar chart from 1946 until 2022, you will see that it is a sad representation of women getting. So are we saying that women just aren't as good in science, they don't deserve the awards, or do we revert back to the, oh, but they don't apply for them? Well, these are nominated awards, so that doesn't quite relate to it. If you then look at the graph below and you look at the percentage of white women versus non-white women, the data is even more shocking. And you can see that the blue bars there compared to the yellow bars and the pink bars, so white women versus non-white women, and then non-white men and white men, you can see the differences. So the proportion of women amongst the recipients of the awards has not changed for over 70 years. And many of us may think that we've made progress, but when you look at data like these, you are less encouraged. Next slide, please. When you come to my world, the world of maternity care and women's health, we have a shocking story to tell in this country where care, especially during pregnancy and after pregnancy, is free at the point of need for everyone. We have really stark inequalities in maternal mortality. And that just isn't because of what we traditionally used to say, oh, they're hard to reach women. They're not hard to reach, actually. It is that they are seldom heard. They come from certain groups who are traditionally not heard and not listened to in the right way. And as a result of that, what we are doing is we have the massive disparity in terms of mortality and even more so in terms of morbidity. And we've had these data for 21 years, and we haven't really impacted on them significantly. So it is what I consider to be shameful data for which I hold myself responsible alongside the systems that enable us to keep these data, i.e. providing systematically unsafe care for certain cohorts of women. It's not good. You can look at the slides later, that they'll be available, and I can go through some of that data in the questions and some of the reasons. Next slide, please. There are so many isms out there in our system, and in particular in healthcare and societally, and I just wanted to pick out a couple of them. The gender pay gap, again, when you look at all healthcare providers in the English NHS, we have significant gender pay gaps, which are normally between 12% or 18 or 19%. We now publish the data, but we're not mandated to improve it by a certain percentage. We're just mandated to have an action plan to try and address them. If you look at the gender and ethnicity pay gap, the difference is even bigger. And this is one of the reasons is that apparently women, like me, consultants, female consultants, aren't as represented in senior cohorts of medical consultants as our male colleagues are. But when you look at national bonus payments, so the National Clinical Impact Awards, that's the system for the non-medics on the call, bonus system for having made a difference outside of your job in the healthcare arena, we see a massive disparity between women successfully getting awards. And then if you again add in women and intersectionality and ethnicity, that's even worse. I have two papers here that I've co-authored during COVID with our researchers at King's College London. We looked at, and we were not aiming to look particularly at the racism and discrimination around how we were providing services to our women during the COVID epidemic, but we also looked at how staff were feeling about it, and a couple of messages came through really loud and clear. The isms, the discrimination, the racism, and the mainstreaming of that during a time where we were all aligned to trying to do the right thing for COVID makes it even more shocking. This isn't about people having genetic predispositions. Why? This is about us not adapting the system enough to make sure that we weren't just thinking a little bit about equality, but that we were integrating equity into everything and anything that we did when we were redesigning services and providing services differently. The COVID story is going to evolve over the next few years, I'm sure. Next slide, please. What we do know is when we talk about discrimination, racism, sexism in particular, we talk about, needing to be just. the story around the isms isn't about being just, it is about patient safety. And I now frame everything around sexism, discrimination of any of the protected characteristics as reducing patient safety. And that is because there are several papers now published on this, including Michael West's paper, 2015, The Culture of the English NHS, which shows you that our engagement as staff, our sense of belonging, our sense of not feeling bullied, undermined, and feeling that we are being supported to progress as well as we can, is a key indicator of engagement and of patient mortality. So this is serious stuff when we're talking about, oh, let's do it, oh, the money's tight, we don't need to do this. Well, actually we do, because it's key to our safety and quality of services that we're providing the populations that we are serving. Next slide, please. So mainstreaming racism and sexism and calling it out is something that is not going to be unusual for any of you on this call, but it is something that I think we should be talking about much more openly and with greater frequency in all the forums that we can. So through mainstreaming it and calling it out, I now talk about the systematic lack of safety for cohorts of women and birthing people, depending on which groups they come from and how they're treated. And in fact, this goes beyond maternity services. If you look at gynecological waiting lists, they have exponentially grown, and they've grown the most out of all waiting lists. But how many times do you hear people talking about gynecology waiting lists? We talk about cancer waiting lists, we talk about orthopedic waiting lists. I have a president of the Royal College of Obstetricians and Gynecologists, Rani Thakkar, feels very, very strongly about this. And when she says something, you might get a publication in the BMJ, you might get a publication in the Guardian, but we are not mainstreaming it. So I ask for your help in doing this in a systematic way as well, so we can start addressing this reverse Swiss cheese effect. When we talk about patient safety, we talk about the Swiss cheese effect. This is a reverse Swiss cheese in that we systematically ensure that certain women have a lack of safety in the services that they are receiving from us and being provided for by us. Next slide, please. So the ecosystem is complicated. It's getting even more complicated and pressured because of money, but the boundaries between the different levels, the me as a clinician providing healthcare, to the service, to the organizational microsystem, to the NHS macrosystem, interplays with politics and society, and we cannot ignore it, because there are frameworks that are holding the current system that results in these inequities and inequalities. And unless we start dismantling them, we're not really going to shift the dial. Next slide, please. I put this up here to talk about the social age of learning, how we exist in the world now and how we make sense of that world. And I also put this in here, if you look at the left side, all of those bubbles there are bias driven. They're bias driven because the basis of knowledge on which we build a lot of things, including the medical curriculum, how we do medicine and the evidence base, is inherently sexist. And until and unless we intentionally address this, unfortunately, we're going to either be unconsciously or consciously biasing the system. And how we make sense of things is also bias. The only bit is in the way in which we tell our stories, and we tell the stories of others, whether it's other women or other communities or other societies. That is the only way in which we are going to change this narrative. So again, that's a call for action. If we want to do it, we need to be thinking about it on a daily basis in almost every conversation that we have. Next slide. But how do we bring this, and how have I chosen to bring this into the services, the service provision, my leadership management of services that I am involved with and responsible for? So I talk about the NHS ecosystem predominantly in any healthcare provision in three domains. There's the operational domain, there's the clinical domain, and then there's the human factors, social capital domain. And it is when you look at it in the three domains that you start realizing, actually, when we're talking about culture, when we're talking about safety, when we're talking about quality, we often are meaning slightly different things depending on where we sit within the system. So what I want to do is to standardize the way in which we talk about it. If we have operational fidelity, if we, the majority of the time, do things as they should be done operationally and have higher fidelity, we know we will have more positive impact. Lots of data around fidelity, impact and efficiency and effectiveness. If we have higher clinical fidelity, if along clinical pathways we do what we should do the majority of the time, because there will always be cases where we need to bespoke it, but those are a small percentage of cases, we will have higher clinical fidelity. And if we do the same with our social capital, if we value and validate people and support them in delivering services to the best of their ability, we will have higher fidelity in that. And if we get higher operational fidelity, higher clinical fidelity, and higher social capital fidelity, what we will end up having is not just a more effective, efficient, higher quality system, but we will provide much more equitable healthcare. Next slide, please. But what often gets in the way, overwhelm bias, and I am not underestimating this at the moment when we're immensely pressured by resources, both financial and human. You get poor leadership because people have overwhelmed bias, people aren't aware, they're not intentional about this true north of really fixing equity so that we then elevate the level of care for all people. It isn't about caring about women more than others, it is about elevating care for all. But we have systemic and systematic discrimination and racism, which means that we're providing poor quality and unsafe care within the NHS ecosystem. Next slide, please. And so having talked about very rawly about what we do, and I think framing it in terms of it's not just a nice to have, it is an absolute non-negotiable necessity. I wanted to finish on a personal reflection. I don't know if you have heard about Ikigai. This is a Japanese concept around a reason to live and discovering what really matters the most to you. Enabling you to live a life of purpose and happiness. And there are four main areas to this. There's what you're good at doing. And for most of us on this call, I suspect operating at the top of our professional license is a key bit of it, whatever your work is. What you can be paid for, because we all need to eat and drink and sustain our families and ourselves. What the world needs and what you love doing. And what the world needs is really around that community, that global community, addressing the issues that we're talking about today, sexism and accelerating action in equity for women. And then the what you love bit. And I am very privileged and lucky enough to have all of these four areas very focused on women in one way or another. What am I good at doing? I am now a very senior obstetrician. I treat women and their babies and their families. What do I get paid for? Luckily for me, I get paid for that. I love doing the work that I do. It is stressful on occasion, but I feel I'm making a difference with the teams, the multi-professional teams that I'm working with. What does the world need? We need to really shift the dial on women's healthcare. Absolutely do, because that's a key bit to shifting the dial for sexism across the world. And what do I love doing? I love the sense of purpose and meaning that this work gives me. So there is passion, there is mission, there is definitely profession, and there is a very strong sense of vocation, which I'm sure many of you will share with me. So the agency to advocate for all women at every level, all the time, in order to eliminate systematically unsafe and potentially harmful care for cohorts of women, it is my Ikigai. And the last slide, please. And I am lucky enough to have even more meaning and purpose added to my life. At 23 years old, that's my eldest daughter and my youngest daughter. When my eldest was born 23 years ago, I remember holding her and thinking, I hope that the world of work is different when you enter it. She has entered the world of work, and sadly, it's not different enough. My 21-year-old is about to enter the legal profession. And my wish for both of them is that in the next 5 to 7 years, we really do shift this dial, shift the dial on healthcare, shift the dial on society, and shift the dial on how we see ourselves and how others see us. Thank you very much.
Thank you, Daghni. I'm just going to have a look in the chat box because I didn't have access during screen sharing. If we've got any questions, or if anybody would like to unmute, if you're able to do so.
I want to know what many of you think.
Claire, would you like to come in?
Hi. Thank you so much. That was really, really inspirational. I mean, and it's wonderful, and I couldn't be a better one to lead in before I say something. So I'm really interested, and this is a lot that we explore with the work that we do with the Institute. You speak so passionately and so embrace about, and so in such an informative way. And you referred at the end to your 21 and 23-year-old daughters. Have you always had this passion, Daghni, or is this something that has come to you in time? And if so, if you don't mind sharing with us, at what point, what has led you to be able to speak in such an articulate and passionate way in as you just did?
Thank you, Claire. So it has, when I reflect back now, always something that's been there, probably genetically. So my father, who was a very, very key and very supportive influence in my life, was a barrister and did a lot of human rights law. So I grew up with this justice thing and equity before really those words were really used in that way, a very strong sense of that. I had a mother who sadly passed away 2 years ago. She'd be 93. She was a gender warrior. Had she been born 30 years later, she would have done amazing things. So I think I had this combination in terms of my upbringing and this really strong self-belief that you could make a change if you want to. You can do whatever you want to, but you do it for the greater good. So that's certainly been something that's been there. I've been a gender warrior all my life. I didn't know that was what it was called until probably about 15 years ago. But when I had my first daughter, and then when I had my second daughter, that sense of purpose and urgency and meaning just doubled. It tripled. I can't explain what it was, but it wasn't just a thing for, of course, I want my daughters to do well. And they are both, thankfully, very, very au fait with this. They've grown up with these discussions. We have very political discussions as a family. They're very passionate discussions, and they've both taken that on in a very serious way. And I'm sure I've had some impact on that. But I do look at them, and I do look at their friends who are females, and I look at their friends who are male, and I think, wow, you're growing up in this society that has added layers of complexity, but we haven't even sorted out these simple things like equity and equality. So it's something that's been strongly there. But I will say, Claire, that my work and my interest has been because of that Ichigai area. I think my passion comes across. I used to say to people, oh, I've got to stand back a bit, it's quite scary. I now own it. And I think actually I'm here to do a job. Just own it. Own that power. Own that whatever it is that people say, take it on, but always help support other women. So it's become a really strong purpose for me, both professionally and personally.
Great. Thank you so much, Daghni. Thank you.
Thank you, Claire. Thank you, Daghni. I misspoke when I introduced your session earlier on. I said gender equality and you spoke on gender equity. Now, Claire, who just asked that brilliant question, is going to speak on the difference of that shortly. But I just wondered whether you could give an example between equality and equity in your practice.
For me, yes, absolutely. So I suppose this is that thing. It's easiest explained when you have the fence watching a football match and you have a very tall person, a medium tall and a short person. And equality is just giving them all the same box to stand on, so they're all a bit elevated. That short person is still not going to have as good a view as a tall person. So in my world, and I think having had many conversations, I understand that there are some potential policy changes, which I'll believe when I see it, to say that we need proportionate universalism. So some women, not because we are blaming them, but some women will need more intense care and more bespoking than other women. And that is a good thing, because when we do that as a system, We are providing that right level. We are enhancing outcomes for that group of women. But in doing that, we're elevating care for all women. So it's the equity thing is making sure that we understand why certain groups have the outcomes that they have. And unfortunately, when you go back to the foundation of all of this, there is so much discrimination in our system, inherent discrimination that, you know, I have it as well. And when someone says, well, how is it APGAR scores for babies? We used to always, whether a baby was black, brown or white, say, oh yeah, pink tick. I've done it for 2 decades of my life. It was only when someone else pointed out to me to say, how is a black baby ever pink? How is a brown baby ever pink at birth? And you think, oh yeah, I've done all that adjusting in there because that was the bias, discrimination that sat within me. So I think that's part of it, Jade. It's not as complicated as people make it out to be. So I think it is about, if you think about the fence, and you need different size boxes for different people, and that's what we should be focusing on.
Thank you, Daghni, for that insight. Appreciate that. Have we got any final questions before we let Daghni go? Thank you for joining us today. It's been an absolute pleasure to have you be part of our International Women's Day talks.